Welcome, everyone. I'm Dr. Carmen Pugliafito, and I'm here today with Dr. Matthew Starr of the Mayo Clinic, where he's an assistant professor and director of the residency training program. Matt, welcome to Retina Synthesis.
Thanks, Carmen. I really appreciate the opportunity to be here and happy to chat with you this morning.
You wrote a very interesting review of the undertreatment of diabetic retinopathy problem. Can you outline this issue for us?
Yeah, of course. So first, I just have to give credit, where credit is due, and I had a lot of help with my trainees first. We've got an excellent, ophthalmology resident at actually Cole Eye, who I met as a medical student, Gabe Kaufman, who's going to be going into retina next year. He took the lead on this and did a really good job in synthesizing and summarizing kind of the data up to the present date. And then, my current surgical fellow, Joe Giacalone, did a good job kind of describing some of the basic science behind, the damage that goes on with persistent, diabetic macular edema, to the retina. And so the goal of this was, and just to kind of reiterate that in clinical trials in the discrepancy that we're seeing in real world data. We get great results in clinical trials in patients who are being treated with anti-VEGF agents, steroids, different kind of agents with diabetic macular edema. But when in the real world, we're not seeing that. And so the paper, what it did was one first, just kind of highlight the problem that happens or occurs when you have a patient who has persistent diabetic macular edema and the pathophysiology behind some of that. And then we went in to kind of summarize the really important pivotal clinical trials that establish our current standards of care for diabetic macular edema and how they may still be falling short. There's a lot of big data, real world studies, from the IRIS database, the Vestrum database, that are highlighting, how we're still, falling short. Our patients are not achieving the same kind of visual acuity outcomes as seen in clinical trials. We're not getting, follow up as, they're getting in the clinical trials. And that was kind of one of the reasons we perceived or, kind of, summarized that maybe this is kind of one of the problems in how these patients are not receiving, injections or receiving treatment. We showed or we summarized that, the more injections these patients receive over time, that the better their vision is over in the long haul. And that only tells a small part, as I mean, there's a lot of different metrics and a lot of reasons why patients aren't going to continue to receive injections that are perhaps futile and may or may not, injections may or may not actually make a difference. We know we're not going to treat someone with significant macular ischemia without edema, and the vision is going to be the same regardless. And so, I mean, there's a lot of different things in play there. But we ended with the physicians need to be kind of cognizant of some of the barriers to care, some of the reasons perhaps for undertreatment, whether it's race, ethnicity, social status, social inequities, disparities of health, and other things that can be done potentially to kind of highlight this discrepancy, whether it's utilizing different modalities of care. There's a lot of interesting kind of newer technologies coming into play and coming into clinical trials, or actually even utilizing artificial intelligence and identifying patients early on, or other kind of pathways or treatment modalities that may best suit that patient.
Well, the dilemma is really one of time and resources. In the IRIS study, the average number of injections that patients were getting in the first year was about 4, compared to the clinical trials where it's 7, 8, 9.
Yeah.
And the main reason for this is really, I think, logistical. Do you agree?
Yeah. I mean, the IRIS database is a great database, but it is messy. There's different parameters that they're kind of looking at. There's different kind of metrics, but yeah, 100%. In the clinical trials, you're going to be cherry picking your excellent patients who are going to follow up. Patients who are not included or excluded, because of follow up, you're not going to be getting those kind of numbers. But yeah, in the real world, maybe let's say the IRIS is a perfect study. You're not going to get you're not capturing, you're going to get a heterogeneous population that's not a clinical trial, patient population.
Yeah. The uh, these clinical trials were done with ranibizumab and bevacizumab in general. The
Yeah,
early trials, the protocol I, for instance, was ranibizumab versus laser.
yeah.
Uh, we have newer agents now with longer treatment duration and perhaps less treatment burden. Do you think that will change things?
It definitely could. I think one of the ones we didn't highlight in this paper was, some of the newer far retina databases. They've included some, 6 month, and I think they're going to get published 1 year data soon on, diabetic macular edema, and those are examining, some of the more recent agents, faricimab, aflibercept, high dose. And so I think that they potentially may offer, better insight into, how patients are doing, with those agents compared to, yeah, like you said, bevacizumab, ranibizumab, there's some of the earlier agents.
Um, so what's your current recommendation for treatment of a patient with center-involved diabetic macular edema with vision of 2050?
Yeah.
How would you
Like,
manage that patient?
yeah, we don't have the luxury of getting a lot of prior authorization or pre-approval. So in our practice pattern currently, we use a lot of bevacizumab, but we generally have a short leash to switch to a higher or a newer agent, just depending on if we can get approval or not. I know that depending on the study, a lot of patients or a lot of physicians will shoot for something like a aflibercept or faricimab right off the bat for someone who's got a good amount of DME and that level of visual acuity. Um, I think that's really reasonable. I think that you're keeping a close watch on it and having a good conversation with the patient and understanding and really kind of diving in and you know emphasizing the need for treatment and the need for follow-up initially I think will help you in the long run. But yeah, I think that there's a whole host of reasons why there's like we haven't even discussed potential undertreatment, but I think these newer agents potentially really will help offset some of those older agent issues with the number of injections that we're seeing.
What about the potential role of TKIs?
That's really interesting. I think that gene therapy, these even we haven't even discussed the port delivery system. These all extended duration agents I think really will help patients and help kind of narrow this gap between clinical trial and real world data. I think those all have a huge potential there to actually start to see some difference. There's like I said, narrow that gap between what we're seeing. Um, yeah, I think you could lump all of those kind of newer TKIs, gene therapy, port deliveries into that kind of extended duration treatment modalities. I don't know. I mean, I'd love to hear your thoughts on it. But, I think faricimab, aflibercept HD. I don't think they're going to get into that 6 month, 9 month kind of ballpark that we're seeing with some of these other agents.
Well, the in the photon trial with high dose aflibercept, out in by year 3, patients were getting an average of 4 injections a year, and that was in the clinical trial. So that's reassuring, but we know that access to these longer duration drugs is now becoming more difficult because of problems with copay support
Yep.
and 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 HMO approvals.
Yeah, and that's another issue. Like, is if it just if these agents are going to help vision, long-term vision outcomes, why are we not starting sooner, and why are we going to be limited by, like you said, copays, insurance approval, prior authorization, when we could just have to keep giving them monthly bevacizumab, and then at some point they're just going to kind of give up. I think that that's a huge issue.
I think the TKIs are very promising. There are two clinical trials that have been at least two clinical trials underway looking at them
Yep.
from both EyePoint and Ocular Therapeutics. Um, and this, a 6 month solution would be wonderful, wouldn't it?
It really would. I think again, the whole host of reasons. Some of them we talked into the paper about just getting into clinic and reducing clinical, our office visits. If we can do that with less injections, that'd be a huge help in, again, narrowing that gap.
Is the undertreatment problem greater in diabetic macular edema than it is in neovascular AMD?
Good question. We're gonna talk about that in the kind of subsequent kind of follow-up review. But I think that you're still seeing some of those, you know, vision acuity differences. But again, that kind of points to the reason that some of these patients are in the clinical trials. If you look at some of the inclusion criteria for a lot of the newer studies, they want to have good, good baseline vision without, subretinal fibrosis, within the fovea. And in real world, we're going to be treating a lot of those patients just because they need treatment. We're trying to, decrease, vision loss, and things like that. But in terms of, if you just look at a, homogeneous population that is comparable to a clinical trial, population, there's still going to be some discrepancies. But I think in general, that thought is that DME under treatment is a little bit more prevalent than AMD at this time.
I think you have a younger patient population, and so getting away from work
Yep.
is more difficult.
Yeah. Yeah, I think that, and then just there's a little bit more, the demographic of the population of patients is different too. And sometimes even our elderly patients, because they can't see, they can't drive, they rely on, family to drive them, to and from appointments, and that's gonna, they're missing work there too. I think that both of these issues, I think, will hopefully you'll continue to be at kind of the forefront of our minds, and how can we utilize our current technologies and evolving technologies to meet those demands.
Well, I think the evidence, though, is clear that the more injections you get, the better the visual results.
I think that is pretty clear too. We've looked at some long-term data, and the patients that continue to receive treatment, higher number of injections, they had better vision.
Yeah. Well, thank you, Matt, for bringing this important issue to the fore, and we look forward to advances in technology and healthcare delivery in improving the care of diabetic macular edema eyes. Thank you, Matt.
No, thank you so much for having me. Happy to chat with you this morning.